Thanks to all the audience who follows our broadcast. We are live on the third day of the 2020 International Web-Based Neurosurgery Congress. Remember, we are streaming on YouTube Live too. Well, we have the honor now to have today Dr. Jacques Morcos. Dr. Morcos is a well-known neurosurgeon at the Jackson Memorial Hospital. He is co-chairman of the Department of Neurological Surgery, professor of clinical neurosurgery and otolaryngology, director of school-based and endoscopic surgery and cerebrovascular surgery programs. Today, at the IWBNC, Dr. Morcos is going to share his lecture, Brainstem Cavernomas, Concepts, Strategies, and Technical Tips. Please type your questions in the Q&A section. We will read them after the end of Dr. Morcos' intervention. Welcome, Professor Morcos, and thank you. It's all yours.
Thank you very much. It's a pleasure to join you on this Saturday, and I enjoyed very much giving my lecture yesterday, Friday. Thank you, those of you who are taking time from their weekend to listen. So I thought I'll talk about brainstem cavernoma, mostly the concepts, the strategies, how to operate on them, and the technical tips. First, I'd like to thank two of my residents, Kat Berry and Evan Luther, and my current cerebrovascular skull-based fellow, Samir Sur, that helped me with the videos and collecting some of the data. And of course, to all the former neurosurgical residents and fellows at the University of Miami, Jackson Memorial System that have contributed to the care of my patients over the many years, and not to forget the patients themselves. So what's the outline of my talk? First, I'll talk a little bit about the anatomy of the brainstem, the pure anatomy, and the surgically applied anatomy. Then about the surgical principles, and I'd like to introduce to you the concept of the goals of treatment, the strategies of treatment, and the tactics in the treatment of brainstem cavernoma in that sequence. Then we'll discuss the surgical approaches you could entertain. And most of the talk will be really on case examples, trying to show you at least my decision-making and some technical tips through the multiple videos I will show you. Let's start with pure anatomy. Obviously, we cannot go into detailed brainstem anatomy in itself. That's a 1-hour talk. So just few things. What is the brainstem? Well, even that is controversial. Do you include the diencephalon or not? For practical purposes, for today at least, I will not. I will talk about midbrain, pons, and medulla. But certainly the diencephalon could be considered the top of the brainstem. And those are the subdivisions that are traditionally followed. So let's talk about rostral and caudal in each of those, medulla, pons, and midbrain. As you can see from these anatomical cross-sections, they have pretty classic appearances. It's no two of them are alike, and let's go over each one of them. Again, there is absolutely no time to go over each tract and each nucleus in each section, but just to give you a general idea where the most important things are, we're going to start at the rostral midbrain, finish in the medulla. Of course, the red here is crus cerebri with the corticospinal tract in it, and the hallmark of the rostral midbrain is the red nucleus and all the other tracts which you can read on the left. Takes us now to the caudal midbrain. You can see clearly the periaqueductal gray here. You can see the medial and trigeminal lemnisci in orange right here, lateral lemniscus. You can see the cerebral aqueduct and so forth. You can see the MLF. Going to the mid-pons, and you will notice the mid-pons, the only so-called bare area is really here, which is the pontocerebellar fibers. Of course, here is a very important corticospinal tract, and the peritrigeminal zone would be laterally, and of course this is the fourth ventricle. Notice the medial longitudinal fasciculus. So one later will be showing possibly an incision in the midline in the fourth ventricle. Realize how close MLF is, and that's, although technically this is a so-called safe zone, it's really not, and I don't like this incision at all, even though it's been classified as a brainstem entry safe zone. In the caudal pons, again, you can look at the pontine area here, the pyramidal system, and you can see the trapezoid body, which has both the medial and the trigeminal lemniscus. You can see the facial colliculus around the sixth nerve, the paraabducens, center for lateral gaze in the floor of the fourth ventricle, and many other things. Rostral medulla, the hallmark of it would be the olive. And so you can think of a pre-olivary approach or a post-olivary approach. Here would be the 11th nerve, and post-olivary would be 9, 10, 11. And of course, you've got the pyramid here, and you've got the medial lemniscus here, and a very busy floor of fourth ventricle, and many other nuclei. By the way, as you will notice on the left, it's a mixture of motor system, sensory system, and autonomic system. And I could have gone into more detail, but clearly no time for this today. And the caudal medulla, similarly, the pyramid. Here we've got the lemniscal decussation, the internal arcuate fibers. You can see them as they decussate, and the dorsal columns as well. So that was just a quick brief over the pure anatomy. Let's go to surgical anatomy. To do this topic justice, you really would have to go back to Albino Bricolo, who probably introduced that concept first. He mostly introduced it from Verona, Italy, by the way, Albino Bricolo. He introduced it mostly for brainstem gliomas, and some of this is from his work originally. You can think of the no entry zone. I put a stop sign here. These are areas you absolutely do not want to enter. And on the right side, even though I put a go sign here, these are supposedly where you could enter. And again, the reason I'm being vague is I think this concept has been taken too far, and people assume, well, if I enter here, I am absolutely going to be safe. No, no. These are relative terms. These are zones you could consider entering, but realize you can still cause significant damage due to the structures immediately next to them, such as a midline incision between the medial longitudinal fasciculus up here. I do not like that incision, and I would avoid it at all. I mean, if at all possible. Yes, you could do infracollicular, you could do supracollicular. I certainly used many times the suprafacial zone and the infrafacial zone after you've mapped the facial colliculus in the floor of the fourth ventricle, or a midline myelotomy between the gracilis nuclei. And what's very useful, as you will see later, is the peritrigeminal zone on the side of the pons. That is a very nice zone to use. So let's go over it in detail. The midbrain entry zone, you could enter anteriorly medial to the corticospinal tract. That would, because remember, the corticospinal tract occupies the middle 3/5 of the cerebral peduncle. So if you enter medial to it, those would be frontopontine fibers, relatively safe to enter. You could enter between both sets of colliculi, and you could enter, that's probably the most useful one in the midbrain, the sulcus, the lateral mesencephalic sulcus. The pons, I would not do that one. That's why I put it in orange. You could consider doing it theoretically and very rarely through an endonasal transclival approach, but that would not be a very safe or very useful approach, since of course you've got the basilar artery right there. But these are useful entry zones in green: suprafacial triangle, infrafacial triangle, the facial colliculus being here. And these are the most useful ones from laterally: supratrigeminal, peritrigeminal, and lower pontine zones around the exit of the fifth nerve. And of course, you can also go more peripherally or posteriorly into the middle cerebellar peduncle. How about the medulla? Again, I would not do this incision here. It is in orange for that reason, between the medullary pyramids, but I would go through the olive, either in front or behind the olive, or posterolaterally, or midline myelotomy. So those would be, in my mind, the most useful ways in principle. So putting them all together, overlaying them on the tracts of the brainstem at different sections, the green arrows are really the approaches I just described to you. So you can get, by looking at this slide, you can get an appreciation, of course, number one, how busy the brainstem is with important structure, and number two, where you have possibly a chance of entering. Again, every case has to be individualized. So then when you say, well, how do you get there? Well, of course, we have many surgical approaches. I'm going to be describing them a little bit later, but this is a quick schematic of what those approaches are, whether you do terminal, cranioorbital, cranioorbital-zygomatic, whether subtemporal, whether you do retrosigmoid, or infratentorial supracerebellar, or interhemispheric occipital, transtentorial, posterior transpetris approach, retrosigmoid again here, whether you do Kawase from the front, or midline suboccipital, or the very useful far lateral approach here. All of those, and even a few more, can get you there. Now, I think then probably the two most important slides of my talk are the coming two slides. If you're going to remember anything, I'd like you to remember those two slides that are coming. So surgical principles, goals, strategies, and tactics. I don't mean this slide, I mean the two slides after that. So the goals are, you have to deal with conceptual reasoning. The strategies is analytical planning of your surgery, and tactics is the practical execution of those strategies. So those are the two slides. This first slide is, I like to divide this concept into four. So how do you get there? How do you find the cavernoma? You want to leave no trace after you've removed it, and you want to remove it completely. Those are your four goals. Because of that, you will have four strategies. To get there, you need to understand surface geometry. To find the lesion, you have to understand depth geometry. To leave no trace, meaning to be safe and not hurt the patient, you need to have optimal intraaxial neural path, meaning you have to choose what is the path of least damage within the brainstem. And lastly, to resect it completely, you of course need some microsurgical ergonomics. Now let's look at each one of those. To get there, to understand surface geometry, how do you apply this tactic-wise? Is positioning of the patient and craniotomy choice. But I remind you, craniotomy, the choice of craniotomy only gives you static exposure. To get dynamic exposure is the second step, so-called dynamic retraction. It would be very rare to put a self-retaining retractor on a case and leave it there the entire case. That's not how I would do it. I generally don't put a retractor, but sometimes you do. But for most of the case, it's dynamic retraction. You have to do arachnoid dissection, intra-op navigation with MRI or DTI. You need choose your entry point in the brainstem. For step 3, for you to leave no trace, you need to minimally distort the neural path around you. You need to avoid this issue of cornering, meaning the blind area behind a piece of brain. You need to preserve the main developmental venous anomaly, DVA. You need neurophysiologic monitoring. And lastly, to resect it completely, you have to evacuate the hematoma if there is one, maintain the gliotic plane, shrink with the bipolar a large cavernoma to gain space. The next one is important. When I say avoid piecemeal resection, well, You cannot avoid it if it's a huge lesion, but if it's a manageable lesion, if you try to keep it all in one piece, you can assure yourself you took it all out when possible. I often use the endoscope at the end of resection for endoscope assistance within a cavity if I cannot see around the corner. And I do resect the draining vein of the cavernoma, not the DVA. There is a difference, and maybe I'll show you later in a video. Every cavernoma has a small draining vein that drains into a DVA. You don't want to lose the DVA, but if you leave the vein itself without resecting it, I have seen it cause recurrence of a cavernoma in the future. So it's a very, I know it's a subtle point, but it's a very important point. This is the second most important slide in the whole talk, is what explains mistakes and suboptimal management results. In my experience over 25 years, what have I learned? Number one, you make mistakes. You can make mistakes in any of the 4 steps at any of the 3 levels I showed you in the previous slide. But particularly common mistakes are the following: not knowing when not to operate. So this is meaning being inappropriately aggressive. Missing the opportunity of when to operate. This is being inappropriately conservative and letting a patient deteriorate and get into a wheelchair before they are referred to somebody who knows how to deal with a brainstem cavernoma. Anatomy does not mean pathology. All these concepts of safe entry zones, even though I showed you nice colored pictures, this is pure anatomy. It is totally meaningless when the lesion distorts the anatomy. You have to adjust your surgery based on the lesion also, or mostly, not just pure cadaveric anatomy. Favorable geometry does not mean favorable physiology. For example, the old way of 2-point method, meaning you choose the center of the cavernoma and you choose another point where it reaches mostly near the surface. You join those two with a line and you say, okay, well, that's the approach. Well, that's incomplete concept. It's useful, but it's an incomplete concept in planning the right approach. The obvious entry point is not always the safest entry point. That is very true when you deal with the 4th ventricular floor, as I will show you in examples later. Suboptimal execution of step 1 and step 2 will lead to suboptimal execution of step 3 and step 4. If step 2 and step 3 contradict each other, you should choose in favor of step 3. Cavernomas, this cauliflower concept. Cavernomas, we say they look like mulberry, but to be honest, many of them look like cauliflowers. They have big protrusions, and you can amputate a protrusion without realizing you're leaving a piece of the cauliflower inside the brainstem through the gliotic plane. So those are common mistakes for the beginner to make. So it's so important when you finish removing the cavernoma to go and really fish and make sure you haven't missed any piece. As I go back to this very important concept, the small vein that goes into the DVA, you have to resect it. Otherwise, you probably will have a recurrence of the cavernoma. Do not resect a large DVA. Inappropriate use of radiosurgery. I'm going to say it probably multiple times. Radiosurgery does not work for cavernomas in general, and certainly for brainstem cavernoma. And it can be very harmful, as I will show you in one of my examples later. Even my good friends in Sweden who do this, where you, of course, a gamma knife was invented, confirm this to me. So it does not work and often creates brainstem edema. So surgical principles, surgical approaches. Well, you know, you open any paper on brainstem cavernoma, you will see tables like this. They list all the surgical approaches you could use for different entry zones, or you look at it the other way. What is your target? So midbrain, pons, medulla, and then what surgical approaches you can do. You know, similar, I've taken these tables from various published papers on the topic. This is the same concept. You can play with the subtleties of that concept. It's all the same, different approaches. And I will show you some of the most useful approaches through the case examples. Bob Spetzler probably has the largest series published to date that I'm aware of. It's about, the last paper was 397 cases, but even in the hands of a master, the morbidity is not low. New permanent post-op deficits in 35% of the cases, resolution of pre-op symptoms in half the patients, post-op hemorrhage in about 8%, and any new deficit in about 53%, which is why, of course, this topic is important to be dealt with at a very, very detailed level. And when you look at when Yashar Kalani and colleagues did a systematic review not too long ago, from about 2,500 patients published, it's kind of similar results. 50% of the time, patients will improve, but you get morbidity post-operatively in a third of the patients, cranial nerve deficit in about 30% of the patients. But, you know, attention to detail and patient selection is very important. So we owe this man, Al Roten, an immense debt of gratitude, and of course, in everything we know in anatomy. And I'm going to use his slides to demonstrate some of the anatomical approaches. So pteryginal cranio-orbitozygomatic or cranio-orbital transsylvian would get you to this zone of the midbrain. Transsylvian pretemporal plus or minus transtentorial would get you to the lateral aspect of the midbrain. I like very much the Kawase approach, and I use it fairly routinely for some complex cavernomas. It is ideal for the upper pons and the midbrain laterally, as you can see from this exposure here. Supracerebellar infratentorial approach, very, very useful approach, is it has 3 variants: midline, paramedian, and extreme lateral. And the most useful is the extreme lateral because it uses the fact that the tentorium is flatter as it goes laterally. And of course, in the midline, it's very peaked, as you can see here. So I like very much the paramedian or the extreme lateral supracerebellar approach. Roten, when he published the posterior interhemispheric transtentorial approach, of course, this is a cadaver. He published it in this position. That's obviously, well, not obviously, but that's not how I do it. But I rotate it 90 degrees. I put the patient on the side, and I certainly wouldn't put a self-retaining retractor. I do put a lumbar drain, and you make the ipsilateral hemisphere fall away from the pons, from the folks, and then you have an excellent view of the collicular plate. I will show you an example of that. You can then cut the tentorium parallel and below the straight sinus. Now, on the cadaver is easy, but in a live patient, I promise you, it is not very easy to identify the straight sinus. It's not always as blue as you think it will be. And navigation can certainly help you in finding it and make sure you don't cut into it. Midline suboccipital telovelar approach, very important approach. It's very important. Think of it like splitting the sylvian fissure. You have to learn that anatomy of splitting the inferior medullary velum, so you don't have to, so you don't resect vermis or enter actual cerebellar tissue. That view gets you all the way up to the cerebral aqueduct, and of course dealing with the floor of the fourth ventricle. Retrosigmoid approach, everybody is familiar with it, and it's a very powerful approach. Look at the extent of exposure it can give you, but you will notice that it will give you a very tangential view. It will not allow you to really corner and go transversely in the transverse plane of the brainstem. That's where the petrosal approaches can come in very handy, whether it's retrolabyrinthine, translabyrinthine, transotic, or transcochlear approaches. It's very rare, of course, to use the transcochlear or transotic or even a translab for a cavernoma, but the retrolab I've used a number of times. I am not suggesting you choose the most complicated skull base approach for a brainstem cavernoma. I'm suggesting that you need to know all of these approaches. Always use the simplest one that will achieve those 4 steps I showed you earlier. Far lateral approach, very, very useful, extremely useful approach for the lower pons and the posterolateral or even anterior medulla. So the rest of the talk is case examples and decision-making and technical tips. So I'm going to take it section by section from top down, and I'm keeping my eye on the time. So if I notice I'm running late, I will, skip a few videos. So midbrain rostral position. I'll show you an example of a transsylvian pretemporal half and half approach. This is brainstem, thalamic cavernous malformation. Here is the view. Here is the cavernoma. By the way, at the top of the videos I will show you, I usually write kind of the important tips I want you to focus on during the resection. Here I wanted to show you the difference between the draining vein and the DVA. In this case, we're going to do Sylvian Fisher splitting. I'm going to skip some early parts of the video. And please notice the third nerve. I am putting a retractor here to help me get to the uncus. And I'm going to keep the retractor in this case later in the case. But during the dissection phase, you don't want a retractor because you're using dynamic retraction. Here is SCA and PCA. Here is the surface of the midbrain. And here we are. We put the retractor again, and I'm choosing the discolored area of the midbrain to enter it. And of course, I'm using navigation to make sure I'm at the correct spot because the lesion is not visible on the surface. Very important to use sharp instruments. I like to alternate sometimes with these suckers that have a blunt tip, and sometimes I use the Fukushima suckers that are lower at the tip but are sharp. It depends what movement you want to do. So you enter the cavernoma and you try to keep it as one piece as you can. In this case, you get the hematoma out, and gradually you stay in this gliotic yellowish plane, and you bipolar what you think are tiny arteries feeding the cavernomas. As you know, cavernoma certainly has a blood supply, even though it is angiographically occult. And what I want to show you is the vein that I will take on purpose. It's not the DVA, it's a vein. I'm looking for it here, and it will appear soon. Here is the vein. You see, there is a vein right here, and if I save this vein, I have the chance of getting a recurrence. So this vein is okay to take because it's actually draining the cavernoma. It's not the deeper large DVA. And at the end, here is a clean cavity, and your job is not done until you inspect every possible piece of what I called cauliflower earlier. Very easy. See, for example, this looked like a small residual cavernoma that I would have missed if I had not looked very carefully. Very tricky. You have to see a number of these and to do a number of these to really appreciate, I think, what I'm saying. And I'm saying this, of course, to the junior people in the audience. When you finish, the brain should look as pristine. And look, saving veins. You have to try to save veins. There is no need to take veins because they just happen to be there. And there's a post-op MRI, looks quite good with a complete resection. Okay, another example, rostral midbrain. This is a thalamo-mesencephalic cavernoma. I am going to use a posterior interhemispheric supracollicular transpineal gland approach. You will see what I mean in a second. This is a classic example of how harmful radiosurgery can be. She's 50. She had sudden diplopia in 2016. Elsewhere, she was diagnosed, treated first time with CyberKnife radiosurgery. She gradually worsened. Now in 2019, dysarthric right hemiparesis, Parinot syndrome, failure of inferior gaze. She was then referred to me. I will show you the video of this. I want you to see in the video where vein of Rosenthal is and how I enter the pineal gland to get to the lesion. I showed you the history. Let me show you. Here is a cavernoma. Can you imagine giving radiosurgery to this massive cavernoma in the middle of the brainstem? Such a harmful thing to do, since there is a surgical approach, supracollicular. Here is a collicular plate. All you have to do is interhemispheric, supratentorial, in the lateral position. This is a 3D video. As I showed you earlier, lumbar drain, let the hemisphere fall down. I had to take this small bridging vein to increase the view. And here is my point about straight sinus. Compare the roten dissection I showed you before with this live view. It's not obvious at all where the straight sinus is. Here is where straight sinus is. I know this because I used navigation, and here is my proposed incision in the tentorium. You cut the tentorium laterally. You don't start at the edge. You make your entry in the middle of the tentorium, and then you go to the edge. Now we're looking at vein of Rosenthal and the quadrigeminal cistern. This is a precentral cerebellar vein. Of course, they both meet to drain into vein of Galen, and you have to sharply dissect this very thick arachnoid of the quadrigeminal cistern, and here is a pineal gland. So the collicular plate is here. It is perfectly fine to enter through the pineal gland, certainly in an adult, and this was the best entry point looking at the navigation, and I chose to do that between precentral cerebellar vein and vein of Rosenthal. You obviously don't want to damage those veins. The precentral cerebellar vein, you certainly could sacrifice it, but I am not willing to sacrifice the vein of Rosenthal. And here is the cavernoma. Look at our trajectory. It's just perfect down the axis of the cavernoma. No retraction, no self-retaining retraction on the occipital lobe, simple gravity. And the rest is the same for every cavernoma I'm going to show you. It's the same principle. You go around, gliotic plane, and here is at the end, very nice view, very nice trajectory to remove entirely. By the way, I forgot to say the CyberKnife, of course, created more scarring around it, so it wasn't as pristine a plane as it would be without radiosurgery. And here is a nice post-operative MRI. Now an example of a caudal midbrain lesion. It's a midbrain superior cerebellar pontine cavernoma that was treated elsewhere through what I consider to be the wrong approach. I will show you why in a second. They did a Thiele-Wheeler approach, but only removed a small portion of the lesion. You will see why in a second. And I will show you a supracerebellar infratentorial extreme lateral approach. I don't use the sitting position. I don't think it's necessary at all. In general, I like the Concord position, and this is such a case. She's 28. She had hemorrhage in this cavernoma in July 2019. That approach was done, as I said, partial resection. She did recover very well, but she still has a residual cavernoma. 6 months later was referred to me with this cavernoma. So here is her original hemorrhage. See, and this is the cavernoma. See, the telovelar is just too far of an approach to get all the way up there, particularly when you realize that there is a DVA. You see, there is a DVA along the way. So the telovelar was not the best approach to choose, and the surgeon did have the DVA in his view, and that prevented him from removing the cavernoma. Here is the DVA on an angiogram, and this is the post-op of that first surgery with, of course, most of the cavernoma there. And this is her later. She did have a very good recovery. Her fourth nerve palsy recovered, and this is how she now was referred to me with the residual cavernoma. So what approach do you do here? Very straightforward. You can see it. The coronal MRI tells you what to do. Supracerebellar, infratentorial approach. I'm going to skip quickly through this video. Here is the view. So we're infratentorial, supracerebellar, no retraction. I mean, no self-retaining retraction. Concord position, meaning the body of the patient is angled. It's not prone. People assume concord means prone. It's not prone. You get CSF from cisterna magna, and you use gravity in your favor. And you can see it's beautiful view. Here is the fourth nerve. Here is the cavernoma. There is no need for the sitting position, although I have no problem people using the sitting position for this. Just in my hands, I find it totally unnecessary. If you use CSF drainage and you use the concord position, and we will remove this cavernoma completely, lifting the fourth nerve to the top superiorly. Again, I'm going to skip cavernoma resection. As I said, they're all the same. Here is at the end. I like these non-stick irrigating bipolar. They're disposable. I use them a lot for when I have to coagulate something very precisely. And this is an excellent resection. The cerebellum is perfectly fine, not bruised. And this is a final view. Concord position, post-op MRI, good resection. Patient had a transient repeat of her fourth nerve palsy. I saw her, and by 3 weeks, completely recovered. So I think this was indeed the correct approach for this one. This is post-op. Look at the DVA. You see, we spared it, of course. You can see why it was in the way of the first surgeon who tried to go from below. That's why it's better this way. Another midbrain caudal midbrain example, mesencephalopontine cavernoma. This is Transylvian pretemporal approach with endoscope assisted at the end of it. I will show you then this mesencephalic cavernoma. I want you to notice the superior cerebellar artery and the use of the endoscope assistance to check for any residual lesion at the end. First, let me show you. Here is a lesion. Reaches the surface of the cerebral peduncle. So it's clear cut that you have to approach this from the front. That's where it's reaching the surface. You could, here you could try to say, should you go subtemporal? Should you go Transylvian? Well, the best of both worlds is to do this, the half and half. Transylvian pretemporal, that's what I did. Here is the incision, craniotomy, Lilliquist membrane, splitting the Sylvian fissure. What I want to show you is the cavernoma. Of course, here it is. It's on the surface. It's not a mystery where to enter. But I, of course, have to deal with the SCA and with the third nerve. And here, it's very useful to shrink the cavernoma. This is one of the principles in the tactics table I showed you earlier. You shrink it to gain some space because the cavernoma is big. And as I told you, I do not hesitate to use a self-retaining retractor when it will help me when I need a third hand. For example, here it allows more light to go in. I'm not saying self-retaining retractors are bad always. No, of course not. They are very useful, but after you have done your dissection and dynamic retraction, then you place your retractor. Don't put it early on and yank on the brain. And here we are, we're going to remove it. And now here is the use of the endoscope. When I removed it all, this is a 30-degree endoscope. Look at the beautiful DVA on your right. You see, very nice view of that. And now I can be sure that since the endoscope showed me that the lesion is all removed. Remember the endoscope, it's another tool. There's not a war between microscopes and endoscope. They complement each other. And here is the post-op MRI. Pons, let's go show you an example of rostral pons lesion. In this case, I'm going to use, it's a pontomesencephalic cavernoma. I'm going to use a subtemporal approach. What makes it difficult this case is this was during pregnancy and she had Cushing, not Cushing disease. The doctors treating her kept giving her steroids and they gave her exogenous Cushing syndrome. You will see what I mean. She known about her cavernoma since 2002. She had 2 previous uneventful pregnancy, but during her 3rd pregnancy at 15 weeks, she had an acute hemorrhage, right hemiplegia. She lived in Panama. She rebled a month later. They put her on high-dose steroids. She was referred to me 23-week pregnant in a wheelchair, severely cushingoid. Here's this young pregnant woman in a wheelchair. Look at what the steroids did to her. Acne, because they felt, and I don't blame them, they felt it was a very difficult lesion to remove. Here is the lesion in pregnancy. So the question is, do you go telovelar? You might think this is the best approach, but that would be wrong in my opinion, because her facial nerve is normal. You're going to give her a facial palsy, if maybe bilateral facial palsy, if you go through the floor of the 4th ventricle. So this is where I said when step 2 and step 3 contradict each other, step 3 should win over step 2 because it's a safer way. So what did I choose? I think it's straightforward, subtemporal. It's reaching almost the surface of the midbrain. That is the better horizontal spread of the cavernoma. Even though it's the left side, but you go subtemporal. Yes, of course, she's pregnant, so you put a lumbar drain. Here is the fetal monitoring during the surgery. That's a fetal heartbeat. I think you can hear it. The baby did very well. Here is a complete resection of the lesion. She did extremely well. Here is maybe 1 day post-op. She actually got better on the 1 day post-op, and you can see her strength got better immediately post-op. And I've seen this in a number of patients when there is an acute hemorrhage and you evacuate it, and if you're, of course, very careful, patients do improve immediately. Not in every deficit they have, but in the most recent deficit. But I never promise a patient you're going to get better immediately. I tell them you might. And those that get better, of course, are very happy. Let's keep going. Rostral pons. I'll show you on pontomesencephalic cavernoma. I use subtemporal transtentorial approach. This is a video narrated by my fellow last year. This is Georgios Zenonos, who edited this video, I thought, in a very nice way. I am going to show you, because he included some nice anatomical. Here is a lesion. Subtemporal approach is clearly the way to go here, but I'm going to show you some of the anatomy that we included and how we analyze the case. You draw the anatomy on a cadaver. You say, we're not going to go over all these tracks, but you say, okay, the hematoma is here. How should you approach it? Do you go this way? Or do you go better this way through the epitrigeminal entry zone? You understand the anatomy, the tracts. So subtemporal, that's all we have to do. save the veins whenever you can. Oh, I want to show you here. You have to cranial nerve 4, fourth cranial nerve.
Is also
this is cranial nerve 3.
A self-retaining retractor was placed to increase the exposure.
I did put a self-retaining retractor after dissection. Now you open the tentorium. Here is the fourth nerve.
But we
Look,
also saw a variant tentorial artery of Davidoff and Schechter.
Artery of Davidoff and Schechter.
This can create a side hole in the PCA, which might be difficult to control without injuring the parent.
So you cut it. This is a trick how you put the tentorium. I learned this from
a small opening in the epitracheal.
Juha Hernesniemi to do this with the tentorium.
The estimated trajectory of the transverse pontine.
We enter the cavernoma and take it out, and you know the rest. It's all the same. Please look how we saved vein of Labbé. The brain looks good in spite of the retraction, because the retraction is done after you've dissected everything. And here is the post-op MRI.
Strength.
And the patient did beautifully. Another example, upper pontine cavernoma. I'm going to go quick on this one. The only thing I want to show you on this case is how you can work between veins. Really, the only part of this case that's interesting is you see those bridging veins. You might be tempted to cut them because we need to get to the midbrain. It's not necessary. There is plenty of space. Work on dissecting them, preserve the veins. Here I am meticulously trying to dissect the vein so I give it more length, so I can do the whole case inside those veins, the triangle of veins. And we did that, and at the end you didn't have to remove the veins at all. Please respect veins when you can. They're not, I mean, I know we have plenty of redundant veins, but no need to risk it. I'm going to show you a caudal pons case where I use the Kawase approach, lower pontine cavernoma. This is a familial cavernoma. Look at the cavernoma when it was small in 2011, gradually grew. Look, it's growing over the years, hemorrhaging, rehemorrhaging. This is lower pons, and it's pointing. And then we did DTI, and we noticed where corticospinal tract were pushed medially. So we said, perfect, we can come from laterally. That's how I do Kawase approach. I like to do a question mark incision, temporal craniotomy. I'm sorry, I'm gonna skip fast through the approach. This is the drill I like to use because it's curved and it has protected shaft. You drill the petrous pyramid, then you open the dura, you cut the tentorium. This is the fourth nerve. And of course, the Kawase is centered on the fourth nerve and fifth nerve. Then we drill a little more. Now I have the view that I want. You see, cavernoma, it's a perfect view down the axis of the lower pons. And here is cavernoma coming out, as much one piece meal as you can. And this is fat graft to put in the petrous apex. This is the approach. I felt it was the perfect trajectory. The retrosigmoid approach would not have allowed me to go around the corner, but that's why I prefer the Kawase approach. Of course, it's more involved and more complicated, but what matters to me is that the perfect trajectory is achieved. And here is the lesion, here is the post-op, excellent recovery. This is a few weeks later. Caudal pons, another example, far lateral approach. You absolutely have to master this approach. It comes very handy again. And again, this is my fellows, Georgios Zenonos and Samir Sur, helping me edit that video. Here is the lesion. You can see it right here. And it's clear, I mean, I think it's clear that you have to go far lateral because you need to go from below. So again, anatomy, by the way, these two videos are published already. Here is the hematoma. And here is where the hematoma is. So how do you could come retrosigmoid, but it's not as good as coming from below. You see, that's the best angle in the axis of the lesion. So that's how I do my far lateral. I still like the hockey stick incision. And you will see the view
confirm the end.
Between 6 nerve.
Eventually, the origin of cranial nerve 6 comes into view, marking the lateral border of the pyramids and our medial border.
Here is 6 nerve. Here is the navigation.
After confirming our location.
Here is a cavernoma right there. And we will remove it. It's a fantastic approach, the far lateral, that gives you so much light in the field and so much maneuverability when you talk about ergonomics of removing a cavernoma. And at the end, I put the retractor at the end to shoot the picture and show the video. You really don't need it for most of the case, as you can see. And
Medulla.
And that's the reconstruction.
Running ball.
Let me see, because I'm running a little bit out of time. It's another far lateral approach. I think we're going to skip that to show you the similar concept. We'll skip that one. I'll show you one example of a medulla.
Yes.
And that patient did very well as well. Let's skip that telovelar approach on a residual tumor. It's actually a redo. I apologize, but I did telovelar and I did mapping. Maybe I can show you the mapping of the facial colliculus. You have to analyze this very well. I'm sorry, it's a far lateral, I apologize, not telovelar tonsillar. This is a recurrent cavernoma that was operated elsewhere, regrew, and we did a far lateral. This is a beautiful view of a DVA after resection. And final view, it worked out very well. So again, an example of how you come from far lateral instead of going through the floor of the fourth ventricle, and look at the DVA preserved at the end of the case. I'll show you one. I apologize, I will skip through those. I will show you one final medulla case and then the conclusion. I'll skip those examples. This is telovelar approach, a medulla case right here. Telovelar approach on this case. You can see the lesion in the floor of the fourth ventricle. It kept growing and bleeding and rebleeding again. And here is the view, straightforward when it reaches the surface. Telovelar floor of the fourth ventricle. You map it, you take a NIM stimulator, and you make sure you're preserving facial. Here is a NIM stimulator. I like to use it as a dissector to go around the lesion, make sure I am saving the facial colliculus. And at the end, the video is not perfect quality. There was some technical issue with the binoculars, but you get the idea. Post-op imaging is a complete resection. Some references from our place related to brainstem cavernoma, if you're interested. And I'd like to put a plug-in for a weekly webinar. We started, actually the first session was this Thursday. Every week, every Thursday at 5 p.m. Miami time, Eastern Standard Time, we are doing cerebrovascular and skull base topics. I have international guests speaking. You can go to our website, to this link. You will see all of the courses that we've put together that are coming. These are the courses. They're a mixture of vascular and skull-based cases. You will recognize the big names of the people speaking with panelists. It'll be a debate format mostly. For example, next week is Fadi Charbel and Mike Lawton. Please join us. This past week was Spetzler and Dan Barrow. And I thank you for your attention, and I will stop sharing my screen right now.
Thank you very much for such wonderful lecture, Professor, and for sharing with us with us those amazing videos and cases. I'm sure all the audience has learned from your robust experience, and surely they have some questions. So right now I'm going to read some of them. Okay, Professor?
Sure.
Okay. I quote Atoumane Fahad. Thank from Senegal. Which entry zone can be utilized in a place where there isn't monitoring? Or can we use all of them as long as the lesion is not deep?
It's a very good question. If you don't have monitoring, you really need navigation. And this is where your knowledge of anatomy becomes even more important. But as I showed you, anatomy gets distorted. So monitoring, for example, you simply cannot do a floor of the fourth ventricle entry without mapping the facial colliculus. It's just unsafe. And simply that case should not be done in a place where there is no monitoring, and it should be referred, if available, to a place where there is. Otherwise, it's increasing the risk of the patient. If there is, because you see, navigation in itself will not help you see the facial colliculus, for example. It's not ideal, but that's the best answer I could give you.
Okay, thank you. Dr. Ricky Novariasha asks, regarding operation monitoring, what kind of monitoring do you use?
Well, it depends where in the brain we are, but for, since we're talking about brainstem cavernoma, it's going to be a mixture of cranial nerve 3, 4, and 6. You put electrodes around the orbit. It's very easy to do. This way you can monitor cranial nerve 3, 4, and 6. You do brainstem evoked potential, meaning hearing. You're putting auditory electrodes. You're putting facial nerve monitoring, somatosensory evoked potential, and motor evoked potential. You can do any and all of those.
Okay, thank you. David Solano asks, how long must be the time between the diagnostic of a bleeding brainstem cavernoma and the surgical intervention?
It's what's his first name? Who asked the question?
David.
David, it's an excellent question. I would say, as a general answer, you want to wait for the hematoma to liquefy a little bit. You don't want to wait too long because the hematoma will disappear. You don't want to operate too soon. So depending on the size of the hematoma, I would say anywhere from 2 weeks to 6 weeks is an ideal window of opportunity to go in. The liquefied hematoma will help your surgical resection.
Thank you, Professor. William Martinez asks, what do you think about the endoscopic techniques?
Well, I hope you saw me. You saw what I showed. It's very good as endoscopic assistance to microsurgical resection to help you look around the corner. And of course, I mean, I'm also a skull-based surgeon, so I use endonasal endoscopy all the time for skull-based work. So it's a very extremely useful tool.
Thank you. Is there a protocol to follow up for incidental brainstem cavernomas?
I never operate on an incidental brainstem cavernoma. I don't think anybody should operate on incidental cavernoma. I usually, if they are familial, I follow them more carefully and more frequently with MRI. But I would usually start with once a year MRI. I'll do this over 2 or 3 years, and then I spread it. I tell them, call me if you have symptoms. Otherwise, if you keep seeing them yearly, they're going to psychologically be destroyed. They're going to think something's going to explode in my head. As you know, the incidence of bleeding from an incidental cavernoma is less than 1%. Based on the papers, if anywhere from 0.3% per year up to 0.9% per year. That's a small number. If they hemorrhage, then the risk of rehemorrhage, depending how you calculate the denominator and the numerator, is approximately 4 or 5% per year. That's why I do treat brainstem cavernomas that are symptomatic or that have hemorrhage, but not the incidental ones.
Thank you, Professor. Is there any role for virtual reality models in pre-surgical planning approach for brainstem cavernomas?
Yes, there is. It's very, very useful. Absolutely. It's very good for teaching. You can imagine if today, for example, I had a virtual reality reconstructed model, I could turn it in 3D and show you the different approaches. You could do it to teach your residents and fellows. Absolutely, if you have it available and if it's not too expensive for you, and absolutely, you should have it.
Okay, Professor. One last question. What about robotic aids? You can use them for brainstem surgery?
No, I don't think that it's very useful for brainstem surgery, like like the Rosa robot or other. I have no interest in those companies anyway. But putting needle biopsy of the brain, I don't think so. Since you have navigation, you're not going to rely on a robot to resect the cavernoma or choose. I mean, you can choose an entry point with navigation, but you're not going to have the robot do the surgery for you. Not yet, at least. We don't have the micro robotics that would hopefully one day take over bypass surgery or resect the cavernoma, but we're not there yet.
Thank you, Professor. On behalf of CIEN, I would like to thank you for your 2 talks that you have presented in this Congress. It has been a wonderful lecture. We are really grateful and honored for your participation in this edition of the Congress. As you know, more than 3,000 people has registered in the Congress, and over 400 people just watched your lecture today. Okay, you are more than welcome to stay tuned to watch more lectures from other speakers. Thank you, Professor.
Goodbye, everybody. Thank you so much.
In a few minutes, we will have Dr. Ajit Thomas doing his lecture, Evaluation and Management of Dural Arteriovenous Fistulas. To get the link of this upcoming conference, please follow the link pin on the chat screen or check the agenda on our website, signedhus.com. Thank you very much.